Hello, good evening, everyone. Welcome back to my IVF&x and the European Fertility Society. We are back once again with Dr. Harry Karpouzis. Thank you so much for joining once again. I'm sure it's going to be a lovely session. And we will start with your presentation. But first of all, Dr. Harry, thank you so much. I hope you are ready to educate us, answer any of the questions that I'm sure we will have. Thank you, everyone, for joining. How have you been? Glad to have you back.
Thank you, Caroline. Nice to see you and meet everybody. It's a very interesting topic, so I'm very keen on presenting and then answer any questions.
Great to hear that. We will talk about embryo transfer preparation, what to do to achieve the best possible outcome, of course. And Dr. Harry Karpouzis is the fertility specialist, but also founder of Pelargos IVF in Athens, Greece. So we are back with you. I'm really happy to have you here. And as Dr. Harry mentioned, we will start with a presentation on our topic, but afterwards there will be time for your questions. As always, please put those in the chat, and we will take care of those questions right after the presentation. Remember, all is recorded, it's all anonymous, so I can only encourage you to put the questions in the chat and feel free to ask anything that's on your mind. We are simply here to support you. We are simply here to help you out with anything any doubts that you might have. So don't hesitate, okay? And now we will go for the presentation, and you can type the questions in the chat right now during the presentation or afterwards. And we can go ahead. Let me know if you can see it, and we can start.
Yes, I can see it.
Thank you so much indeed.
So hello again to everybody. We'll talk about embryo transfer and how we can prepare for the embryo transfer and what are the best preparation for the embryo transfer so that we can improve the chances of success. First of all, we all know that embryo transfer is a very critical step in the IVF success, maybe the most important one. As a medical act, it's usually a very easy medical act in comparison to egg collection, in comparison to creating a very personalized protocol. It lasts usually about 5 minutes or even less than that to start till to finish. But when the embryo transfer is tricky, it can be very tricky, and it is a very stressful actually for the doctor and for the patient as well step of the IVF procedure, because you've been through everything. You've been through the injecting yourself every day, taking medication, creating protocols. Many times you have managed to create a good egg donation embryo or an embryo that you have done PGT8 and it is your only healthy embryo. And then suddenly there is a doctor, a catheter, and you know that the whole IVF, the whole attempt is over there. So this is stressful for the patient and for the doctor as well, and it needs to be done correctly. One mistake and the whole IVF attempt might be destroyed. So, the whole preparation for the embryo transfer includes before embryo transfer and the same process of embryo transfer and what is happening after the embryo transfer. And this presentation will try to explore most of the evidence behind the protocols to prepare the endometrium actually for the embryo transfer, and to say a few things about what is the best way of doing an embryo transfer actually. This slide is not full. I don't know why. It's missed most probably. But by any means, let's talk about the protocols of endometrial preparation, which is what it leads to the embryo transfer. First of all, we can have fresh transfers. In our unit, the big majority of IVFs nowadays, it's frozen transfers, because on frozen transfers, we vitrify, we freeze the embryos, It's been proven that nowadays with frozen transfers, we have equal or even better chances of success in comparison to fresh, because with fresh embryo transfers, the implantation window can many times be affected by the hormones. So we have restricted a lot, actually, because we are using a lot of PGTA as well, the fresh transfers. Of course, if everything is absolutely fine, we can go ahead for a fresh transfer, but it's the minority. So when we talk about frozen embryo transfers, a frozen embryo transfer can happen on a natural cycle for women that are ovulating. It can happen on a modified natural cycle, and we will talk what is this about. It can be on a cycle with letrozole, for example, which actually produces an ovulation. It can be with HRTs, estrogen and progesterone, and it can be after down regulation as well. Injections like GnRH agonists, like gonapeptyl, like Lupron, like Zoladex, all this medication. Let's start about the natural cycle embryo transfers. We have the embryo already, it's a frozen embryo, yes, and we need to decide how we will transfer it, what's the best technique. It can be transferred on a natural cycle. This is sometimes ideal in women with regular cycles. It has some benefits. It has the benefit, of course, that the women do not utilize hormones, avoid medication, have less side effects, the cost of the medication. It has some downsides as well. If someone doesn't have a very regular cycle, it can be very tricky to find out when the ovulation will happen. And even if it is a regular cycle, you need very good monitoring of the hormones to identify exactly the late surge, because you can very easily miss the late surge, which means the natural ovulation, and then the whole cycle can be cancelled. The benefit behind these cycles is that it has been proven that they have been associated with less risk of hypertensive disorders and preeclampsia in pregnancy, in comparison to a cycle with hormones. If you compare the evidence, it's a bit conflicting, but most of the studies show similar outcomes to, estrogen and progesterone frozen transfers. Of course, like in estrogen and progesterone frozen transfers, the endometrial thickness needs to be good in size as well. Sometimes we might have issues with the thickness of the endometrium in a small minority of patients, which is improved if we give later on HRTs. The main thing, though, when you deal with medical tourism, because right now we are talking mainly about medical tourism, it is that it is a very difficult cycle to coordinate it. And that's why we try to avoid it, unless for people that can be here for long period of time and can afford of losing a cycle to repeat it again. And this is the reason that we usually don't prefer to transfer embryos when someone is from abroad on natural cycles. Otherwise, it's a very good option, actually. Modified natural cycle, it means that we use Ovitrel usually to trigger the follicle when the follicle is ready. The advantage on that is that it improves scheduling, can reduce the preterm late surge, can make the endometrial profile more predictable. In this case, you need medication after, before the embryo transfer, after the trigger injection, like progesterone support most of the times. When we compare the chances in comparison to hormone replacement treatments, it's more or less the same, avoiding a lot of medication like estrogen and progesterone. And when you compare the chances in comparison to a completely natural cycle, you have a less cancellation, a less chances of cancellation of the cycle, because you can control it better, you can trigger better with Ovitrel. When a follicle is ready, you can trigger, and then you can do the embryo transfer like 5 days later. Now, semi-natural cycles, it means that we give medication to produce ovulation. And this is usually in people that do not have absolutely regular cycles. We give medication, usually letrozole or clomid. The clomid is usually avoided because it can affect the thickness of the endometrium. It produces ovulation. It makes more certain that ovulation will achieve. It can shorten a bit the cycle. It can program a cycle better. It may improve the lining in comparison to a true natural in thin endometrium cases. It controls, of course, as we said, the ovulation in women with cycles that are not very regular. They don't do ovulation every month. And in this case, the luteal support to give medication like progesterone, etc., is needed before the embryo transfer and after the embryo transfer. It's an alternative of embryo transfer without using hormones, actually. And the most common thing that we usually do is estrogen, progesterone. We can add to the estrogen and progesterone other medication depending on the case, personalizing the case, like steroids if we have recurrent implantation failures or recurrent miscarriages, like antibiotics, like aspirin, like anti-clotting injections. Every medication that we give, it needs to have a reason, of course, and it needs to be personalized. But as a general rule, the hormonal replacement frozen transfers start by taking estrogen. The ideal thing is to take between 12 to 18 days of estrogen, and then you start progesterone, and you do usually the embryo transfer about 5 days later when we have blastocysts. We work in our unit mainly with blastocysts in a very big percentage of patients. So this is requires usually about 5 full days of progesterone before you do the embryo transfer. There is no clear evidence about how much estrogen we need to give. Most of the studies say that more than 8 milligrams per day do not offer an additional advantage, but in women that have problems within endometrium, we can increase the doses even to 10 to 12, even to 14 milligrams per day. We are doing it in our unit when needed in women with low thickness of endometrium. And in these cases, we understand that we don't want to have ovulation. The estrogen that we give on these doses, they prevent ovulation, but of course, they don't prevent ovulation in 100% of the patients. So we have some patients that develop a follicle and we may have a premature ovulation, which can destroy the cycle again. But of course, it's much more easy to control them. And this is why we prefer them in women that are coming from abroad, and especially for women with irregular cycles, or women in the perimenopause, or of course, women in the menopause that cannot do a cycle on a natural cycle or a semi-natural cycle. These women, they need to go ahead with hormone replacement treatment. The downside of these hormonal replacement treatments is that we don't have a corpus luteum. We don't have this follicle that produces naturally progesterone, which exists, for example, in a natural cycle. And this means that we don't have some vascular markers like VEGF or relaxin. So it is associated, and we need to say that to people as well when they are having, hormonal replacement frozen transfers. It is associated in a small degree in an increased risk of hypertensive disorders during a pregnancy if they finally get pregnant. Now, the last possibility is to give estrogen and progesterone, but also to downregulate the ovaries before with injections like gonapeptyl, like Arvacap that we have in Greece. When do we do that? We do that when we have clear evidence of endometriosis, of adenomyosis, sometimes when we have fibroids, and when we suspect endometriosis sometimes as well. It suppresses the pituitary. It prevents completely the risk of ovulation. The disadvantages is that it lasts longer. It has a higher cost. It might give you some symptoms like hot flashes and night sweats. And in the patients that I talked about, it can increase the receptivity, but sometimes it can affect the thickness of the endometrium as well. So when we have thin endometrium in previous attempts, usually we prefer to avoid it unless we have a very specific reason about it. What is the right thickness in order to do an embryo transfer? The ideal thickness is more than 7, but to be honest with you, when we have more than 8 is better, and when we have more than 9 it is even better. When we have more than 12 or 14 or 16, this might be on the opposite, not so good, on the other hand. Of course, it's not only the thickness, it's the way that it looks. If it is a trilaminar, a triple line or not. We have clear evidence that when it is less than 7, it has a reduced pregnancy rates. Of course, we do have pregnancies even with endometrium sometimes of 5.8 or 6 or 6.5. And what we can do if the endometrium finally is not good at the time of the embryo transfer. Initially, the most reasonable thing to do is to cancel the cycle, to try increasing the dose of estrogen if we are in this situation, giving different ways of estrogen from vaginal, from patches, from the mouth. We always check as well the reason of why an endometrium is thin. For example, we need to do a hysteroscopy. We need to take biopsies for a chronic endometritis and sometimes give antibiotics. When we have recurrent implantation failures, we might check the implantation window with a test which is called ERA or ERMAP. We use a lot in Greece in cases of recurrent implantation failures or recurrent miscarriages in immunological testing as well, so that we can give additional medication like intralipids, Placanil, like steroids when it is needed. And of course, when the endometrium is not good, even after investigations and we haven't found the reason of why it is happening, there is some data behind sildenafil, Viagra, not conclusive, of course. We use a lot in unexplained cases or in cases that we have HLA and KIR we use the GCSF, which is either with an infusion or with an injection. Aspirin can increase the blood flow. The GCSF, the Neupogen, can be used together with the PRP or alone by itself. Of course, to give all this advice, not often in thin endometrium, but in women that are preparing for an embryo transfer, to stop smoking, to stop having... to check the thyroid and make sure that the thyroid will be okay, to reduce stress. Acupuncture, we have a very good acupuncturist working with us, and either as a stress relief or a placebo or with several mechanisms, it has been proved that it can help an embryo transfer and also thin endometrium. Sometimes we have seen it. If it is not working anything for a thin endometrium, we can use platelet-rich plasma treatments or stem cell therapy sometimes, which is an experimental treatment that we use sometimes in Greece. And of course, when we have increased the doses of estrogen and still the endometrium is not okay, and we have investigated everything and nothing works, sometimes what I do in my practice is that we check on a natural cycle to make sure that in a natural cycle the endometrium is not getting thick as well. Because sometimes we have noticed that when we have an ovulation follicle, when we have a follicle that sometimes can happen later in the cycle, suddenly on a natural cycle the endometrium is getting thicker rather than in women that are taking very big doses of estrogen. And sometimes this works in persistent cases. Now, and then you prepare yourself. Okay, you take multivitamins as well, which I haven't put a slide on, and the vitamins, they depend on many things. Of course, you need to take vitamin D. Of course, you need to take folic acid, antioxidants, depending on the case, especially if we have endometriosis or if we have polycystic ovaries. NAC is a medication that we use many times, and it has some data about helping, especially in situations that need antioxidants and anti-inflammatory medication. In polycystic ovaries, sometimes we give glucophage, metformin, because it has been proved that it can reduce the risk of miscarriages in polycystic ovaries. The cocktail of vitamins to prepare yourselves for an embryo transfer, it depends slightly on its case, but it has some basic steps as well. So we prepare everything, we do the protocol, we decide on the protocol, and then we are over there and we do an embryo transfer. And we know that the whole IVF, the whole costs of the IVF are inside a small tube in the hands of a doctor. And how do we do the embryo transfer? The embryo transfer, the golden standard is under ultrasound guidance. In the old times, we were doing it blindly, but now that we have the ultrasound, it needs to be done with ultrasound guidance. What type of catheter you use? If you don't have any previous history, if everything looks okay, every doctor uses the catheter that is more familiar with. We have soft catheters, we have rigid catheters. The important thing at the time of the embryo transfer is to suspect a difficult embryo transfer and not to find yourself in front of surprises. If you have a history of previous embryo transfer, which is difficult, you need to do a mock transfer. You need to see if it is possible to happen. If we have women with previous loop-led treatments because of HPV, these are women that might have scar tissue, adhesions. So you need to suspect that the embryo transfer will be difficult. And when you suspect that the embryo transfer will be difficult, don't hesitate to do the embryo transfer under sedation. It's much, much easier. It causes less contractions. It doesn't put you into all this stress to relax, sleep, and try to do it this way, because this way we can grab the cervix, we can move the cervix, and all these things can be quite uncomfortable when you are awake, when we suspect an embryo transfer that it is quite difficult. You have different cervical canals. You have cervical canals sometimes that naturally they might have a step inside. The doctor needs to have the experience to know the catheter to use. In situations like that, for example, it is better to use a soft catheter to pass the catheter inside, to follow the natural flow of the cervical canal. When you see or you suspect that there is a pinhole external loss of the cervix, it is better to know that you need to use a guidance or a rigid catheter so that it can pass through that. And also retroverted uterus, either from endometriosis, from scar tissue, or natural retroverted. We say to women to full their bladder, and sometimes they full the bladder a lot. So you need to empty the bladder in cases like that to improve the view and to make it easier. On the other hand, when the bladder sometimes it's very underverted, for example, in severe endometriosis cases, one very good trick is to fill the bladder so that you can push it back and then grab the cervix possibly and try slowly to pass a catheter. It's very difficult to fail an embryo transfer. It hasn't happened to me for a long time, but it can be quite tricky. And you need to be very well programmed for an embryo transfer because it's not good to refreeze embryos. Let's go to the next slide, which actually I have already talked about. And what's for the end? To debrief. Like everything in IVF, for embryo transfer as well, there is no one-size-fits-all. We need to choose the protocol, the best protocol to reach the embryo transfer. We need to choose the right vitamins to give in order to go for the embryo transfer. We need to monitor the endometrial receptivity and not only the endometrial thickness in cases that we have recurrent implantation failures, recurrent miscarriages, and things like that. It's not only the thickness. A transfer technique can make or break a cycle, and experience is very important, not in a straightforward embryo transfer, but in complicated embryo transfers. The less the maneuver, the less the contractions, the more the chances. Prepare, as I said before, do a mock transfer before, suspect when it will be difficult, do under sedation. Very important, and that's it.
Brilliant as always. Thank you so much. That's it. Sounds like it's so easy. Thank you so much for walking us through, but I do think it's a little bit more complicated than it looks like sometimes, right? So thanks a lot for introducing us to that. Now we will go for your questions. There are plenty of those right here. If you have more, you know what to do. Go ahead, type those in, and I will start with the first question that we received. It's a bit of a longer question, so let me show you the details. So how risky is doing PGTA on frozen embryos? 5 embryos frozen at 38. No transfers done to date. One natural conception. One conception since total of 2 healthy live births. And you can see the details here. Now 43 want to do PGTA before transferring any embryo. 4BB, you can see the details again, but clinic in Ireland says PGTA is not reliable. I want to try reduce time to transfer and try to avoid further miscarriages, but clinic doesn't recommend PGTA due to risk damage to embryos. Unreliable results, mosaics may correct themselves, etc. So can you explain the risk of PGTA on frozen embryos?
I haven't understood completely if we are talking about embryos that are already frozen from the age of 38, or if we are talking about doing a new stimulation now and do PGTA in the age of 43 before we freeze the embryos. The answer is easy. I mean, there's data that says that if we have already frozen embryos, to defreeze them, to biopsy them, to freeze them again, and then defreeze them compromises the quality of the embryos. It is not clearly associated with changes in the risk in the chances of implantation, but it is clearly associated with increasing the miscarriage risk. So you compromise an embryo when it is already frozen to defreeze it and biopsy it. So the answer is no, and especially if we are talking about embryos frozen in the age of 38, transfer them. Now, if you are 43 and you are thinking about doing a new IVF and you want to freeze the embryos, to PGTA the embryos before you freeze them, the answer is yes, do it. I mean, the documentation of the PGTA results is very important, and you need to know in the unit that you will be going what exactly are their thresholds. Yes, when you take a biopsy of a PGTA, it's from the outer part of the embryo. It doesn't always correspond to what it is inside. But when you have less than 30% euploidy rate, it's considered to be a euploid embryo, a mosaicism rate. It's considered to be a euploidy embryos, and it has very good chances of success. When it is more than 80%, is a non-euploid embryo, and the truth is that it gives you close to 0 chances of success. And when you have a middle category between 30 or 80, I'm saying now the percentages in our clinic, okay? It can vary, and that's why you need to ask. It's mosaic, and when you have a mosaic embryo, some of the mosaic embryos maintain some chances of implantation when they are low mosaic from specific chromosomes, etc. What do you need? Genetic advice. We offer a genetician to advise you. You need to know that if you transfer an embryo of a low mosaicism, we will not throw it away. It will not give you 70% chances, but if you don't have a euploid embryo and you transfer a low mosaic, it might give you 30% chances or 20% chances. So you take the risk and you transfer it. Consented decisions, and yes, in the age of 43, I would PGTA. If your embryos are from 38, I wouldn't PGTA. Yeah.
And you can see there's additional information. Frozen embryos already at 38. Yeah, no plans for more stimulation. Yeah. So I think that's pretty clear. Your answer is pretty clear here. Okay. Hope that helps. Let us know if there's anything else you wish to add, of course, wish to ask anything else. And thank you. I hope that was useful. Let's have a look at the next question. Lots of those. Thank you so much. Keep them coming, of course. So in cases with high NK cells, what protocol do you recommend for frozen embryo transfer, medicated, natural, modified, natural frozen embryo transfer? And if so, why?
It's not that simple. And also, I mean, I'm a bit about immunology testing. What immunology testing? Testing in the blood, testing biopsy inside. I mean, we need to know that when we take estrogen and progesterone, these hormones affect the local immunology. I mean, for example, in cases, not of course in everybody, but in cases with recurrent miscarriages or recurrent implantation failures, we propose very often with PGT8 embryos before a frozen transfer, a test which is called IMAP, which actually takes a biopsy inside the lining of the womb after preparation, after estrogen, after progesterone, or in a natural cycle, but at the right timing. Because, you know, hormonically, what happens in a normal cycle with what happens in a HRT cycle that mimics a normal cycle, it doesn't make a lot of difference. So when you take a biopsy at that timing, you know what is the immunology at the time of the embryo transfer, and you follow a personalized protocol. And this protocol might tell you that you are over-suppressive or under-suppressive. If you are over-suppressive, you might need steroids, you might need hydralipids, you might need Placanil. If you are under-suppressive, you might need additional luteal support, like Ovitrel injections or more progesterone. And also the result might tell you that you need a higher dose of estrogen or lower dose of progesterone, for example, because progesterone changes the immunology as well. So you get a personalized approach and you do the protocol depending on what is happening on your natural profile. Now, if that will happen on a natural cycle or a medicated cycle, it depends on other things and not only immunology. It is much easier when you deal with medical tourism to program it. And that's why we are using estrogen and progesterone cycles.
Okay. Thank you so much. Again, not an easy answer, but of course, if you have anything else, let us know. Okay. Okay, that's next question from Sarah here. I was also told testing could falsely eliminate good embryos. So to give a better implantation chance, it's best to transfer on day 3. Is it factual or an opinion?
I don't agree with that.
Mhm.
I don't agree. We don't do it in our unit.
Yeah.
We don't do day 3 transfers. Okay, in a laboratory that respects itself. To be honest, if an embryo has got chances of reaching day 5, will reach day 5. If it doesn't reach day 5, it means that 99%. If you transferred it on day 3, it wouldn't have worked. As I told you before, it cannot really eliminate good embryos.
Mhm.
It can create mosaic embryos that under the best consultation and, after talking to a specialist who is a geneticist, you get a consented decision on what embryo is transferable and what embryo is not. An unemployed embryo, which means more than 80% of, mosaicism rate, it gives you almost zero chances of implantation.
Yeah, pretty clear. Again, thank you so much indeed. Let's have a look at the next question. It's about the error test, which was done in October 2024. Will the result be still valid with a transfer in December 2025? And additional information here on a related note to the first question, my clinic told me PGTA is only performing good blastocysts, got 5AA, 5BA, and 6AB. What is your opinion? I don't want to waste medium blastocysts, 41-year-old.
Okay, it's good questions. First of all, we need to know that the ERA test is having lower and lower evidence behind it. Of course, new ERA tests might be coming. The knowledge behind the implantation window might be changing. We use nowadays ERA testing in unexplained failures of implantation that we have investigated everything else and they are still not working. In a scenario to be completely true, and if we think behind the implantation window, yes, it might change. The implantation window, if someone is pre-receptive or post-receptive, time can change it. The truth is that usually it doesn't. Okay, so in cases like yours, because I had this question before, if it is your only precious and only embryo and you have checked everything else and you haven't seen anything, okay, by completely by the book, repeat it, do it again. but the possibilities are small to change if someone is pre-receptive or post-receptive to change later on. And it had a second part in the question about the PGTA with medium. Yes. I mean, the number of blastocysts that you check, it depends on the age that you are. To increase the chances of finding even one of them that will be chromosomically normal. If you ask me, I have seen euploid embryos in BB embryos grading, okay, which came back euploid, and I have seen aneuploid embryos in AA, and I have seen pregnancies with BB embryos that are euploid. The truth is, if you have like 9 or 10 embryos and you are like 40 years old, you can choose to biopsy the best ones that give you the better chances. Okay. And hopefully you will get the embryo that you want on these. If you don't, you can either decide to analyze the remaining ones as well, or you can say that you don't do that. We usually take biopsies from all the embryos in our unit. Now, if you will choose to analyze 5, 6 of them, 4 of them, depending on your age, or all of them, it's a different thing because it goes per blastocyst, the cost. But we usually take the biopsy from all of them because you usually do PGTA in cases of recurrent implantation failures, of recurrent miscarriages, and my theory behind putting an embryo that is not checked about the chromosomes is that if it fails again, if it miscarries again, I will come and I will tell you, listen, it might have been the embryo. And this answer in my ears, if I was a patient, might not be good to me. So that's the reason that I say that when you have the history of doing PGTA, transfer embryos that you know that they are healthy. Because otherwise, if they fail again, you will not know what is the reason.
Yeah. And that way you actually know, that it wasn't the embryo in this case, Okay. Okay, again, not easy answers for your questions, but thank you so much. I hope that is helpful. I do believe so. And let's have a look at the next question. So what treatment is prescribed for high uterine NK cells? How different is it from the treatment used for high blood NK cells?
Listen, it's not much different. What I'm trying to say is that because it's a very conflicting issue and there are different theories behind immunology, we consider it to be more accurate to take a biopsy at the time or after endometrial preparation from the inside of the womb rather than in the blood, because we think that what is happening in the blood sometimes does not correspond to what is happening in the uterus, which is what we are mostly interested in. The treatment generally, if you do blood tests, will be more or less the same. Yes, because if we get the natural killer cells come high, the Th1 to Th2 is over suppressive. I mean, again, you will give steroids, you will give intralipids, you will give plaquenil if needed. Okay, and so it doesn't change dramatically as far as it regards that. What it changes is what you believe more. You believe more the blood tests or what is happening inside.
Okay. Again, thank you so much indeed. Again, we will have a longer question with some details here. 38-year-old, AMI 0.9, 2 blastocysts, 1 euploid, 1 aneuploid. Frozen embryo transfer protocol modified natural. My one and only euploid failed to implant. On immune protocol, tacrolimus, steroid, aspirin, plexane, 28-day cycle, progesterone level 88 days, before frozen embryo transfer, 10.5 millimeters endometrial thickness and perfect trilaminar, dominant follicle before trigger, 14 millimeters. Question 1, would you recommend unmedicated frozen embryo transfer next time? Second question, what's your acceptable progesterone level before the transfer, and what's your clinic dominant follicle before trigger modified natural? Thank you, Ellen, for your questions.
Yes. Okay. Most probably, I would recommend a frozen embryo transfer. Most probably, I might have investigated about possible endometriosis. There are some specific tests that you can do about that if you don't want to check with a camera. If we suspect endometriosis, because many times there is endometriosis and you don't suspect it, I might even consider downregulation with RVCAP injections or gonapeptyl injections. Since your modified natural cycle did not work on a euploid embryo, if you have another euploid embryo, and we don't know the grading of this embryo as well, because this plays a role as well, I would change the protocol either on an HRT cycle, yes, or a cycle with HRT and downregulation if we suspect endometriosis as well. The progesterone levels, we measure them. We are of the units that we measure them before the embryo transfer. Usually the lower threshold is about, it's a good embryo. So usually the lower threshold is 12. We don't have an upper threshold. And to be honest with you, there is nothing like that in the reviews. In women that have endometriosis, there is progesterone resistance. So in women that have endometriosis, many times we target higher on the progesterone levels rather than lower. This is one thing that we are doing. And what was the last question? There were 2 or 3.
Sorry. Yeah, let me go back. Sorry, just give me a second. I need to find it. Just a second. I think that was it. Yeah. What's
clinic
your
dominant follicle before trigger? I mean, it depends a bit on the endometrium to be okay as well at that timing. We usually trigger with at least 14, 15. Yeah, some units trigger with even 12 if the endometrium is okay. We measure a bit the blood tests as well so that we don't have an unexplained early luteal surge that might have a preterm premature ovulation and you don't realize it. But yes.
Okay. Thank you so much indeed. Next question in regards to the embryo transfer. So do you think that cramps after transfer are a bad sign? One of my doctors said that they sometimes use Buscopan to reduce cramps for better success. Anything you can advise here?
It's okay. Yes. I mean, Prolutex, for example, which has a very quick lifespan, it acts quite quickly. It is a muscular relaxant as well, and it can help in cases like that. Many times it's not associated to really cramps. Many times it might be associated even to bowel movements, and you think that it is from the womb. But cramps generally is a sign. So when someone complains, as far as it regards us at least, we do give them a Prolutex or a Lentogest or a progesterone, which is muscular relaxant, to help a bit with that.
Okay. Thank you for the clarification here. And can retroverted uterus have a negative impact on transfer in implantation?
Not really, no. I mean, retroverted uterus, 15% of the patient, they have it because they are born like that. If you do the transfer properly and you leave the embryo properly, it shouldn't affect. Sometimes retroverted uterus is associated with endometriosis and adhesions and scar tissue. In cases like that, endometriosis itself reduces the chances. Yeah.
Right. Okay. Thank you. Let's go ahead with the next question. What is the reason that RVCAP, I'm not sure here, sorry, can enhance receptivity?
It cannot enhance receptivity. It is used in specific category of patients, and this category is patients with adenomyosis, patients with endometriosis, or patients that we strongly suspect endometriosis, or in women that have fibroids, average size, close to the cavity, that you want to reduce a bit the size of them before the embryo transfer. All these patients are helped by RVCAP and by GnRH because they reduce actually the disease of endometriosis, of adenomyosis, or the size of a fibroid. Yeah.
Okay. All right. Thank you. And now let's go for the next question from Catherine. I'm currently using Centros peptide for 7 days plus Progenova, 3 a day oral, 3 per day, right? Orally before my last embryo transfer. What protocol is this? Are you able to tell us?
Okay, most probably it's additional medication to make sure that you will not ovulate preterm. So, for example, you might have in the beginning of the cycle a follicle which is slightly bigger. And if you have a follicle which is slightly bigger before you start the progainova, the progainova might not be enough to prevent an ovulation. So most probably your doctor is afraid about this follicle ovulating before its time, and the cetrotide helps on that. So we do it as well in some of the cases.
And I will show you a follow-up here, just additional information if it helps. Sorry. So I use Crenone to post-ovulation the previous cycle.
Okay.
Anything?
Crenone is a medication, vaginal medication that has progesterone inside. I mean, many times we give luteal support, we give progesterone support after the ovulation and before the embryo transfer. Usually we don't do it in natural cycles, but sometimes in modified natural cycles or letrozole cycles, we use this medication to support a bit, to give a bit of luteal support before the embryo transfer. So you can use Crenone or you can use other medications, cyclogest or utrogestan or Prolitex. Any clinic has its own protocol.
All right, perfect. Thank you so much again for that. And let me go to the next question. Thank you so much. So many questions from you. If endometrium thickness is around 7 millimeters due to low dose of estrogen in the first 4 days of the cycle and there's follicles growing in the ovaries, is it still okay to proceed with the embryo transfer, or is it better to cancel the cycle? There's any impact? Is there any impact of having?
Yes, I mean, one of these follicles, if it keeps growing, it might cause the ovulation. So check the progesterone to make sure that ovulation hasn't happened, because if it has happened, you need to cancel. Also, 7 millimeters endometrium is not an ideal thickness. It's doable, but not an ideal thickness. So it depends on how many days you take estrogen. And if you take estrogen only for like 7 days or 8 days or 9 days, increase the dose of the estrogen and push more, because the endometrium might get thicker. We usually give between 12 or sometimes even to 18 days of estrogen. This is usually the implantation window, so that we can keep pushing and pushing to increase a bit the thickness of the endometrium. Now, if in the meantime a follicle grows and ovulates, then unfortunately you need to start again from the beginning.
Okay. Again, brilliant. Thank you so much. We will be slowly finishing, so if there's anything else you would like to add, go ahead, type this in, and I think we can still answer some of your questions. And here's the next one, a bit of a different topic. Any advice in vaginal uterine microbiome and how this affects implantation?
Yes, there are some studies about all these things. We use the relevant tests as well, either through blood of a period or with a biopsy. We don't use it, of course, in everybody. We use it in people that have recurrent implantation failures or recurrent miscarriages, because there are some studies that associate it with. I mean, if you have chronic endometritis, then yes, you need to take some antibiotics. Even though, you know, the latest data now in ESRE as well, the last Congress shows that actually antibiotics in chronic endometritis towards, you know, placebo treatment might not be really doing the job. But it's still early. If you know that you have failures of implantation, miscarriages, and you identify something like that, you treat it, or you take probiotics, because there is some data that you need to have a good flora inside, you know, the cavity of the womb or the vagina in order to improve the chances of implantation.
Okay. Again, thank you so much, Angelina, for your question. let me go ahead with the next one. And I think you've mentioned this. So can a painful, difficult, and traumatic transfer be the cause of embryo death?
Of failed implantation, and yes, I suppose we need that. Yes, it's not ideal, a traumatic transfer, and the more the manipulations, the more problem. Okay, contractions might be caused. The ideal thing is to be smooth, but it's not always easy to be smooth. Okay, sometimes it is impossible to be smooth.
Right. Okay. Thank you. Again, short question here. Advice for transfer in anteversio, retroflexio. I'm not sure here. Can you help with that?
I'm not sure. Most probably, it's a question regarding what I said about the techniques of embryo transfer in undiverted or retroverted.
Retroverted, yeah, I think
Okay,
so.
so what I said is tricky transfers. It doesn't mean, I mean, sometimes you have an undiverted uterus, like most of the people, and it is very easy to pass the catheter. And sometimes you have a retroverted uterus, and it is again very easy to pass the catheter. Now, in acute situations, it might be tricky to pass the catheter. So there are the techniques that I explained in my presentations that can help a bit, to make smoother the embryo transfer and help you pass the catheter and do the embryo transfer.
Right. Okay, perfect. Thank you so much. I think it's crystal clear right now. Can you advise on this question? So Aima would like to know, what form of progesterone do you prefer for medicated cycle, and do you check blood progesterone levels in the transfer cycle?
We do, yes, we do, mainly about the minimum threshold levels. We use combination of vaginal progesterone together with Prolutex subcutaneous injections.
All right. We already answered the question what you can do before an embryo transfer. We already mentioned what kind of vitamins you would advise to take before. We already talked about ERA test as well, so I will skip those and I will go to some other here options that we have, and anything you can advise here. Is there evidence that IVIG treatment enhances implantation and pregnancy rates in cases of elevated NK cell activity?
There is some evidence. There are some studies. We don't use IVIG because it's very difficult to find it and to administer it in Greece. Instead of that, might do the job medication like Placanil, tacrolimus, combination with steroids, intralipids, more or less they are doing the same job. But yes, there is some study behind it.
Okay. Question that we definitely receive quite often, but what's your take on that? Would you PGTA donor eggs from a donor that is in their 20s?
No.
Crystal clear, yeah? So not for egg donation. I mean, is there any particular reason that you sometimes do it?
We don't do it. It's not allowed, first of all, in Greece by the law. But I don't think that, there is some benefit behind it. To be honest with you, it's a traumatic procedure. Yes, with good embryologists and experienced embryologists, the risk of the injury of the embryo is very, very minor. But you remove some cells from an embryo. And you need always to balance the advantages towards the disadvantages. When someone has recurrent implantation failures, recurrent miscarriages, or is more than 38, 39, 40 years old, the advantages are more. When we're talking about a young girl who is 20 years old and has been checked for her karyotype, her chromosome analysis, and many conditions, and she's 20 years old, the advantages are not more than the disadvantages.
All right. Very important to know that again, as I think. Possibly our final question for today. I think that's a good question to finish with. So 45 plus with 2 euploid embryos, 6 AA and 4 BB. What should be the suggestion? Transfer 1 each time or both? In case of one, for which would you start?
I would start obviously with the best one, most probably the 6AA, but it depends as well. You need to discuss with your embryologist and with your laboratory. I mean, the 4BB, is it day, both of them are day 5, not day 6, right? If both of them are day 5, the AA one is the best embryo, and we usually start from the best embryo. Yeah. Yes. Now, one or both, I mean, it gives you good chances if you transfer an AA euploid embryo. And you are 45 years old, you need to take into consideration all the risks as well from a possible twin pregnancy. So I would try one. But again, it's a discussion that you need to make to yourself and the doctor as well.
Definitely. As I mentioned, it looks like that was we have some more questions, but I'll be happy to forward those to Dr. Harry and his team at Pelargos IVF, and I'm sure they will be happy to give you some more details. As you already seen and know, I'm sure we definitely need some more details to give you a proper answer to each case, because I know that you put lots of information, still might not be enough to give you a proper information, and so you can decide what's best to do, right? But thank you so much, everyone, for your questions. It's been a great session, and I know that we could go on for 1 hour more and more, possibly even more. So thanks a lot for that. And Dr. Harry, as always, it's been great. Lots of questions you've answered today. I hope you are also happy with how everything went. Any final words before we finish for today?
Nothing. I am very happy if I helped. Some questions were very interesting indeed. Thank you for coordinating all this. We'll be available for anything that you need to book a free chat, discuss anything. You can find us at pelargosivf.com. It's the website. To everybody that is having an embryo transfer, I wish good luck.
Definitely. Thank you so much. Fingers crossed as always. And remember, we will be back. Actually, tomorrow we will talk about ICSI and whether it's something that should be included in every cycle. So if this is something you would like to learn a little bit more about, you can join at 7 p.m. London time. It's Ask Your Doctor event with 2 doctors from Latvia and Ukraine. So please join us. You can go to myivfenses.com and you will be able to find out a little bit more. And thank you so much, everyone. Dr. Harry, as you can see, lots of thank yous coming up your way. It's been great to have you. I know we will see each other quite soon, so looking forward to it already. Have a lovely evening, everyone, and see you soon.
Bye.
Take care. Bye.